Hello, in this video, we're going to talk about hypertension during pregnancy. Hypertension during pregnancy is common. A woman may be hypertensive when entering pregnancy, or she can become hypertensive during pregnancy. Pregnancy is divided into 3 trimesters: first trimester, second trimester, and third trimester. Hypertension during pregnancy can be very serious and can cause problems, and therefore a pregnant woman with hypertension is often a high-risk patient. There are different types of hypertensive disorders in pregnancy. Week 20 of gestation, or week 20 of pregnancy, which is around the second trimester, is an important mark to remember. And the reason is that week 20 is where the different hypertensive disorders during pregnancy is classified or divided into. Hypertension diagnosed before week 20 of pregnancy is called chronic hypertension. And this is hypertension diagnosed again before pregnancy or before week 20 of gestation during pregnancy. But it's important to remember that during pregnancy, there's usually a drop in blood pressure, specifically diastolic blood pressure. So if you have an increase in blood pressure or hypertension anytime during pregnancy, it's somewhat abnormal. If the pregnant woman has an increase in blood pressure first picked up after week 20, this can be either preeclampsia or what's known as gestational hypertension. And there is a big difference between preeclampsia and gestational hypertension. In preeclampsia, which is a more serious form of hypertension during pregnancy, there is an increase in blood pressure, which occurs after 20 weeks pregnancy. And there is a presence of proteins in urine or systemic features of preeclampsia, which we will talk about later. But these systemic features include vision problems, liver problems, and even kidney problems. Gestational hypertension is very similar. There's an increase in blood pressure occurring after 20 weeks pregnancy. But the difference is that gestational hypertension, there is no systemic features like what we see in preeclampsia. The systemic features I'm talking about is part of preeclampsia, and this video will now mainly focus on preeclampsia. The signs and symptoms of preeclampsia include headache, visual disturbances, right upper quadrant pain, which relates to hepatic ischemia. There's also reduced urine output. There can be low abdominal pain, which can be a sign of placental abruption, which is more common in patients with preeclampsia. On clinical examination, preeclampsia can reveal signs of pulmonary edema, hepatic tenderness from the hepatic ischemia. There can be peripheral edema and hyperreflexia. You can remember the triad of preeclampsia as hypertension, proteinuria, and edema. The exact pathophysiology of preeclampsia is unknown. However, several changes have been identified in preeclampsia. Number 1, vasoconstriction leading to hypertension. 2, there's platelet activation with intravascular coagulation. 3, endothelial dysfunction, which contributes to the edema, fluid shifting from the vascular compartment into the interstitium. And 4, maternal plasma volume contraction. Preeclampsia is life-threatening because it can lead to a number of complications, including eclampsia, which is essentially seizure, pulmonary edema, renal failure, and even stroke. Preeclampsia not only affects the mother, but also can cause fetal complications, including intrauterine growth problems, restriction, placental abruption, as mentioned earlier, and stillbirth. If a patient with preeclampsia presents with pervaginal bleeding, placental abruption must be on the radar. The risk factors for developing preeclampsia include having a history of previous preeclampsia, prima gravidarum, the first pregnancy, a family history of preeclampsia, having pre-existing hypertension, diabetes, renal disease, obesity, and some connective tissue diseases such as rheumatoid arthritis and systemic lupus erythematosus. A pregnant woman presenting with hypertension during pregnancy needs to be investigated. And the differential diagnosis will be based on when the pregnant lady presents, whether it is before 20 weeks or after 20 weeks, they have hypertension. Regardless, with hypertension during pregnancy, it is important to differentiate between chronic hypertension, gestational hypertension, preeclampsia, and something called chronic hypertension with superimposed preeclampsia. Investigations of hypertension during pregnancy include a full blood count, electrolyte urea creatinine to check for kidney function, a liver function test to check for liver function, checking for urea creatinine ratio, urinary dipstick, which may reveal proteinuria in preeclampsia. It is also important to perform fetal assessment, so using an ultrasound to check for the fetal anatomy, blood flow, and any signs of growth restriction, and then doing a cardiotocogram to check for fetal heart rate. The management of preeclampsia. Specifically, it is important to assess the need for delivery. So delivery, I mean delivering the baby. Indications for delivery in a pregnancy with preeclampsia. 1, there's progressive maternal organ dysfunction. 2, there's inability to control the blood pressure with other means, including medication. And 3, the fetal well-being is compromised. At the end of the day, the only way to stop preeclampsia is by delivering the baby. Management of hypertension during pregnancy can be treated with medication, including methyl-dopa or labetalol and clonidine. When the plan is to deliver the baby from the mother, an antenatal corticosteroid injection are given, and this is in order for fetal lung maturation. And this is done if the fetus is being planned to be delivered before week 34. And the corticoids, the steroids, are given to the mother 2 times 24 hours apart. Finally, a side note, it is mandatory to assess the mother's blood pressure postpartum after delivery to be sure that the blood pressure goes back to normal.